New York City. Although one of the most affluent cities in the world, there are some communities that still struggle daily with poverty, lack of access to education, food insecurities, and many other social factors that can contribute to poor health. Now, the Family Health Centers at NYU Langone seeking to generate better health in the Big Apple through research and service, providing care to more than 130,000 people, ranging from infants, teens, adults, and seniors. Centers looking at the bigger picture of health and wellness in the city, starting with the impact of social factors on health. As a part of our Chasing the Dream initiative on poverty and opportunity in America, we'll take a deeper look at these factors and their role. And here with more on this and to help us understand this, Family Health Centers of NYU Langone's Chief Medical Officer, Dr. Isaac Dapkins, its Vice President of Community Programs, Kathleen Hopkins, and its Executive Director, Larry McReynolds. So welcome to all of you.
Thank you. Thanks for having us.
This, as I've been learning about this, it seems like such a fascinating initiative. And part of it seems that, well, why haven't we been doing that before? And I'm going to ask you all about that. And then how it is that we think this can improve healthcare. But I think the first question, and Larry, I'll ask you this. The first question is, how did this get started at NYU Langone?
Sure. So we are a federally qualified health center. And federally qualified health centers were started 52 years ago in the country because, as you mentioned, access was the original problem that people had, that they didn't have access to health insurance or access to a doctor. So the federal government at that time did an experiment to put community-based clinics in underserved areas. So 52 years ago, there was no such thing as Medicaid. And at that time, you had to come to the ivory tower to get care. You had to make the big trek, to the academic medical center. And what happened was people were not engaged in health care. They were a number. They wouldn't make the trip. They wouldn't seek care. So roll it forward 52 years. Now we have Medicaid. We have clinics that are in underserved communities. And so the access issue is starting to go away. So we've got school-based clinics, we have community-based clinics. And now you start to understand the other issues of healthcare. It's not just about accessing healthcare, but understanding who is that person. So a doctor will want to do clinically best practice medicine, but how do they apply it to the unique situation that every person is in? Treating a diabetic that's homeless is different than treating a diabetic that is in college. Treating a pregnant woman of Chinese background is much different than treating someone of English background. Some cultures may not assume that you need to see a doctor, that it's a natural condition, so you only go to the doctor when you're sick. And so as time moves forward, and as we look at the United States, who spends more and more of their money on health care, but the health of the population is not getting better, and we compare ourselves to other countries who spend less on medical care and more on social services around care, they have better outcomes. So that's what led us to this point.
And that is a fascinating paradox, the notion of we spend more than anybody. And yet when the studies come out in terms of where we fall on the list, it's always staggering to see where we are. So the first question then was access, have a place for people to go. Then you get to this notion of social factors. And doctor, let me ask you this. As a physician, again, as we sit here and talk about it, you say, well, that makes sense. Various social factors are going to have an impact on health. But have we always actively engaged in that notion and tried to create and provide health care that has a correlation to social factors?
Well, I want to start by talking to you about what a doctor-patient relationship is. You come in, a patient comes in, sees a doctor. Over time, you get to know each other. A doctor diagnoses or identifies conditions that people have. And then they create a plan of care. They say, I want you to take this antibiotic, or you should go see this other type of doctor, and what's been the experience of folks who work in settings like this is that patients can't really actually achieve the goals that are set for them. They don't actually end up getting the medicine. They can't really end up, for a variety of reasons, getting to see the next doctor in care. They may not And so when you start to think about, and people who've been working in community health centers and community health like myself have recognized this for a long time, what we haven't really done is systematically try to identify what the factors are that interfere with these treatment plans, and then bring to bear resources that can help people achieve their goals. And I'll give you just one quick example. If you don't read, and I give you a piece of paper telling you how to take care of your diabetes, it doesn't go anywhere unless you have somebody who can help you. And so really what Kathy has put together, the Family Support Center, it fills in that gap. It allows people to connect the dots. It helps us bring to bear resources that have not really been thought of as the medical provider's problem.
So, Kathy, how do you do that? Because I think we understand all the concepts here, but then you have to get it done. How does that happen?
So, interesting you asked Larry before, like, why haven't we been addressing these issues before this? But in reality, our organization has been addressing these issues for probably close to 42, 45 years, right? Early on in the organization's history, they realized that health is not just about physical well-being. It's about all of the other factors and systems that affect a person's life. We don't live in silos, right? We live in contexts of individual, community, and family. And so it began to think about what are some of the barriers to care that our patients come up against, and how, as a healthcare system, can we start looking at addressing those barriers. So over the course of 40+ years, we've developed a system of care outside of the healthcare environment, so outside of the four walls of our medical practice, and in the heart of community, addressing all of those social risk factors, starting from prenatal to early childhood centers, to adult education and workforce development, to older adult services.
What then have you found, and all of you can jump in on this if you will, what then have you found have been the most significant barriers to good quality health care? And what now are the centers doing to try to get over those?
I'd like to start with two things. One is the whole idea of how am I going to pay for this? Community health centers, that's not an issue. The first question out of our mouth is not, well, what's your insurance plan? Or what's the copay?
And that must be an enormous relief, I would think, to a lot of patients coming in.
And so that's a social determinant of health factor for many patients. They don't know if they're going to be able to afford the treatment that you're going to prescribe. We take that barrier away. Now, we do that through a lot of federal support and other support, but just removing that as the issue that is going to affect whether a patient can really follow the treatment plan is very important. Another very important thing is cultural competence. If a patient feels that you're not going to understand them because they don't speak the language or you don't speak their language, if they come from a different background than the doctor does, they may have this perception of you're not going to take my concerns seriously, or I may not be able to express what I'm truly going through. You know that New York City has many, many immigrants, and that brings with it a lot of issues. We don't care about immigrant status. We care about you as a person. We're not trying to, figure out, what your citizenship status is. We're trying to make sure that you can be healthy, so that you can get a job, so that you can provide for your family. And so I would say that those are two or three of the most important issues. Kathy?
And then the other is really so we have this cadre of services that are available. Even our community-based partners that we work very closely with offer a lot of services. How do we intentionally connect our patients to those services in a meaningful way where they actually get the services that they are entitled to and can lead them on a better trajectory to good health outcomes?
Talk about some of those services, how they work, and how, as a physician, how you can be involved in these services.
I'll give you a classic and an incredible example. We provide, I think we delivered 1,600 babies last year, and we had not been meaningfully screening women to determine whether they have issues with housing. For example, we started doing that, and we relatively quickly identified 3 women who were pregnant who didn't have a place to stay. Now, I mean, I have 3 children. I can't imagine what that's like. So by connecting with the Family Support Center and then connecting to housing agencies that are in Brooklyn, we were able to help those individuals get connected to a place to stay. That itself reduces stress. Stress has always been associated with bad pregnancy outcomes, and it also sets the stage for early childhood development later on. It has such implications. So it's really about, so the one thing that's really, I think, different on the medical side is that we've started to intentionally screen or ask questions to try to identify some of these factors. And that's really led to a systematic revision of how we think about what we're asking people that's going to lead to their health outcomes that we want.
So what other kind? We've talked about some of these things, some of the screenings. What other things are available for the patients?
So food insecurity is another issue, right? That's part of what we're asking people. Have they been worried not having enough food for their children in the past month or so? Have they worried about meeting rent obligations? And in asking those questions, again, connecting people to benefits that they may be entitled to, like a WIC program or food stamps applications, or if it's an emergency issue, there are food pantries in the community. So help with immediate short-term mitigation, but also looking at how on a long term can we increase this family's resources so that food insecurity will not be an issue to them, and knowing that food insecurity affects someone's diabetes status, affects rates of childhood obesity in community.
All interconnected, part of the fabric of their lives, I would think. Well, you know that NYU Langone has had this long and rich tradition of caring for members of its community. I think the Family Health Center is another illustration of the work that they're doing. It's just fabulous work. Much to be done, I'm sure, as you all know, but we have to get started someplace. And hopefully this will become a model for other hospitals throughout the country. I want to thank you all for spending some time and sharing your thoughts. And maybe we'll down the road, we'll check back in with you and see how things are going.
Thanks so much.
Thanks so much.
Appreciate it.
You'll be well.